Absolutely, my pleasure. All right, good to go. Mhm. And actually, yep, I certainly fit the phenotype.
Pop that into that pocket inside. Good morning, everyone. I'm Mark Musin from the Stanford Center for Biomedical Informatics Research, and I have the pleasure of introducing this morning's speaker. Before I do that, let me give you some coming attractions. On February 8th next week, Maureen Bisignano is going to give a talk on discovery, leadership lessons from challenging situations. The following week, the speaker will be Michael Pignone, who will talk on colorectal cancer screening 2017 update. And Sumbul Desai will speak the following week with a topic that hasn't been announced yet. This morning, I have the pleasure of introducing Nigam Shah. Nigam came to Stanford about 10 years ago at around the time when the Institute of Medicine, now the National Academy of Medicine, started to make lots of mumbles about how what we needed were learning health systems. No one exactly knew what that was, but it was pretty clear that you could go to Safeway, use your Safeway card, and Safeway would know everything about you and everything about other customers and identify best practices and marketing guidelines and learn from all the data that had accumulated. We in healthcare do the same thing. Well, we acquire lots of data, but we don't always learn from it. And even though our data may be acquired in a way which is not compatible with clinical trials, may be highly biased, there's a lot of it out there. And Nigam has been spending his career trying to figure out what to do with it. I think what Nigam has done is take the idea of the learning health system and really shown how it can scale. And I think there's probably no one in the country who can do it better than Nigam can. Nigam, as I said, came here about 10 years ago after completing a PhD at Penn State. Before that, he got his medical degree in India. And for the past several years, he's been working really hard on taking the data that come out of our own electronic health record system at Stanford and showing us what we can do with it. And I think what's very exciting moving forward, Nigam wants to develop a mechanism whereby we actually individually can learn from our own patients and from patients like our patients in attempts to have better health care. Nigam.
Thank you. So Mark has been one of my strongest supporters, and so you shouldn't believe all the superlatives he says, but everything else is correct. So it's a great pleasure to be here and talk about an informatics consult. As many of you know, informatics is now a board-certified subspecialty, and it's about time we open a clinic. And so the original idea was to call it an informatics clinic, but then that creates some confusion around patient care and all that stuff, so we called it a consult. All right, so I'll start with a pretty picture. It doesn't show up yet, I know that. We hear this big data stuff all the time. And I want to distill it down to one slide to give us a little map as we go through the presentation. So think about three things: people, or samples, if you will, or patients, and features or characteristics or variables about them, and then things unfolding over time. So if you have electronic health record data, you're looking at millions of people, thousands of variables, ICD-9 codes, CPT codes, lab tests, and stuff like that. And then they tell you whether somebody got a drug. We don't know. You explicitly said don't give it. Same thing for diseases, devices, procedures, and so on. So a lot of this stuff is explicitly negated, which is kind of a useful thing to remember. So that's what the -1 denotes. And then you have the time dimension. Of course, it's not as clean. People don't come to you every Monday or every Wednesday. They come to you when they have a problem. So it's not the time axis is not nicely sampled. Then there's the workhorse of epidemiology, claims data, or administrative data, billing data, if you will. And there you have millions of samples, hundreds of variables. The nice thing, you can go back about 8 to 10 years. In the EHR side, you can go back about 6 to 7 years and get good data. If you go past that, it gets pretty spotty. Then we have what I call quantified self kind of data, which is measure everything you can about yourself, your genome, your microbiome, your perspiration rate, your heart rate, oxygen saturation, what have you. You typically get it on hundreds of people if you're lucky. And the problem is, what is a feature? A lot of you might believe that the step counts that come from whatever wearable device or phone you have is a good enough feature, number of steps per day. There is no good definition of what constitutes a step. And if you put on an Apple Watch on the same wrist or on one on each wrist, and at the end of the day, you'll get different step counts, which is like physiologically impossible. And it'll be off by like 30%. So I'm not talking 1 or 2 steps here and there. And so there, engineering the feature is the current challenge. And then, of course, when you get into the omics, you have 6 million features or variables, billions if you go to the single nucleotide level, and then you have, again, thousands or so samples. And in some sense, it's nice because any model will fit. And in some sense, it's hard because you have 6 million ways of getting things wrong. But it's really important to be doing this because that's how we move the science of medicine forward. That's how we understand disease. That's also the public imagination about big data. We're going to measure a lot of things on a few people that will tell us how diabetes works or how rheumatoid arthritis progresses or how cancer progresses. And therefore, we will do medicine better, which is true, but it's driving the science of medicine forward. So when I take this picture and reconcile this, okay, so that's that. And the problem across both these sides of the data spectrum is we do a lot without knowing what works. Like we take care of patients, we design the next phase of experiments, we figure out what variable associated with what other variable or what outcome without really knowing what works. We make treatment decisions, we make prescription decisions, we prescribe 4, 5, 6 drugs to people without ever testing 5 drugs in a randomized clinical trial. So we do a lot without knowing what works. All right, so on this campus, I'm sure you would have heard precision health. There's precision in the science of medicine, which is measure millions of variables on people to figure out what's going on and why. I usually have trouble with buzzwords, so I kind of have to break them down into discrete chunks for me to understand. So this is my one bullet point on the media version of precision health or precision medicine. Then there's precision in the practice of medicine. The idea being, let's examine what we routinely collect on millions of individuals to make care better for the next person, otherwise known as epidemiology, or just good medicine. You try to remember what you did for the last 100 cases and then do a better job. The new buzzword is learning health system. And then the often forgotten, but precision in meeting of patient's goal of care. It's really important, but we often forget that people have priorities in life that are beyond just getting their chemotherapy. And on this campus, actually, we have efforts around this. Abraham Verghese leads the Presence Initiative. And I think it's kind of important to keep this in mind, that is an integral part of precision health. And on this campus, 80% of the press releases are here. I would say about 15% here, and then we make a few chit-chats about the last one. All right, so that's the cartoon version of precision health. So let's get into the informatics consult now. So what is this thing that I'm talking about? Given a specific case, we want to provide a report with a descriptive summary of similar patients in Stanford's clinical data warehouse, the common treatment choices made, and the observed outcomes after specific treatment choices. That is what the informatics consult is. Just like you can refer a case to radiology or pathology and get an opinion, we can give you our opinion based on what we have in the data warehouse. It's an IRB approved study for 1 year. Now, why do I want to do this? So I have 3 simple bullet points. I like lists of 3 if you can, if you've seen the trend by now. Randomized clinical trial-based evidence is available for a small fraction of situations. Those of you who practice know that you might have a guideline, and when a patient walks in, the chance that they perfectly match the kind of individuals based on whom the guideline was generated is small. Just a back of the envelope calculation, about 19–20% of guidelines from the American Heart Association are RCT based with level A evidence. And if you say that they're applicable about 20% of the time in your patients, we have our 4%. And then the other big problem, more than half the published studies might be wrong. Like we all know John Ioannidis and the work of the metrics center here. The problem is we don't know which half. And then the last one is we can learn from the experiences of patients by querying the data for patients like mine. So you put the 3 things together, we have a problem and we have a potential solution, so it's worth trying. That's basically my justification of why this is a good idea. All right, so how did I get on this path? So when I joined as a faculty member, the learning health system discussions were at their peak of their hype cycle. This paper had just come out in the New England Journal of Medicine called Evidence-Based Medicine in the EMR Era, and that was describing the work that Jennifer Frankowitz did on making a treatment decision for a 13-year-old female with systemic lupus erythematosus. And what she did was to look at, she queried the data for patients like mine. It's not patients like me, it's not the motivated patient, it's the doctor doing the query, to answer the question that what is the risk of a thrombotic complication for her patient. So 13-year-old menstruating female, and she didn't want to start thrombolytic therapy unless the risk was high enough to make that justified. So she had an IRB approved protocol for studying kids with SLE for research. So she started querying and found 98 pediatric patients that had lupus. 10 of them had this outcome, and she's searching for this outcome using these 3 keywords. Back then, Stanford was amongst the few institutions, I might even say the only institution, that had the ability to do free text searches on clinical documents. Not my doing, this is the STRIDE team. Then she searched for the various risk factors, and you can see here for anti-phospholipid antibodies, she couldn't query labs, so she's querying for a surrogate from medical practice that you only give aspirin to a kid if they're positive for this particular laboratory test. She's getting a few counts, and then in some long division to get a risk ratio. So all of this was fine. There was one sentence in the paper that says, and based on this, we chose to use thrombolytic therapy for the patient, which got her into trouble with pretty much everybody you can imagine. And privacy, compliance, IRB, went all the way to the dean, the CEOs of the hospital, legal. And the story is that within 24 hours, everybody thought about this and said, this is the right thing to do. This is why patients come to Stanford for. And everybody signed off, and the paper got published. So when I met with Jenny and then with Chris Longhurst, the question we posed to ourselves is, could we do this in a more systematic and a more automated manner? So we built a system, which I'll show you in a few slides, that allows us to create these things, which I'm going to call a patient feature matrix. And then on that matrix, allow me to search for terms and concepts and group them into variables, very similar to saying thrombus, thrombosis, blood clot is my surrogate for the outcome of thrombosis. Counting is the easy part. And then we did a new study. Well, first we reproduced our old one, and then we did a new study where we profiled the risk factors for chronic uveitis. So kids with juvenile arthritis are at risk for chronic uveitis, and they have to be seen by an ophthalmologist every 6 months. People go once, twice. If you have 2 kids and a career, very few people show up the 3rd time if the kid is fine. And chronic uveitis in kids can lead to blindness. So it's a real screening need. So we said, all right, can we find risk factors? And again, this study was driven by a question from a parent of a patient that Jenny was seeing, asking, could allergies be associated with uveitis? So first, we test 4 things we already knew. And that's really important, because life doesn't work as advertised when you get to millions of patients. Your notions of p-value are guaranteed to be wrong. Your notions of confidence intervals are guaranteed to be wrong. Your notions of false discovery rates are also likely to be wrong, so you have to empirically estimate how often can you be wrong. So we tested 4 things. If your arthritis is oligoarticular in onset, starts in less than 4 joints, there's an increased risk of uveitis. Yes, we see that. If you're positive for anti-nuclear antibodies, there's an increased risk. RF factor positivity is protective. Psoriasis or a history of it increases your risk. So sanity check, 4 things we knew work out. And then we tested allergies using the allergy medications as a surrogate. And yes, there's an increased association. This is a question we ask at every doctor visit. Do you have allergies, and are you taking allergy meds? So we don't need FDA approval for this screening test. And if somebody answers yes, let's schedule an ophthalmology visit for them, which is also the recommendation. So then once we had this and that system, which I haven't shown you yet, we kind of went on a roll. More terms and concepts, more variables, more counting. And then we asked, the last one we did was asking, does the use of androgen deprivation therapy in treating non-metastatic prostate cancer elevate your Alzheimer's risk? And here again, first we test 5 things that we know for sure are wrong, as in there is no association. And I want to make sure that when I test things that I know are not associated, I don't see an association. So this is the idea of what I call empirical calibration. Then we test a few things we know, like age and history of cardiovascular disease, and then androgen deprivation therapy. And yes, there's an association. This paper made a decent amount of news. We got 4 letters to the editor saying, well, but Alzheimer's can be misdiagnosed. I mean, it could be vascular dementia. How do you know for sure? So that's where, having spent a couple of years with Mark, I knew these things called ontologies that allow you to group things into larger categories. So vascular dementia and Alzheimer's all meet at dementia. So we said, let's re-ask the question with dementia. Turns out you don't even need to do statistics at this point. There's a 15% risk, about 5 to 7 years out, increased risk of of getting dementia. All right, so we did a bunch of these studies, which is nice. You need a clinical fellow, about 4 months, and a few rounds of coffee, and someone willing to write it up. So this is the system underneath that allows us to do this. We have data coming in from multiple sources. There's textual data. There's, of course, the coded data that comes straight. We process it through multiple text processing pipelines that allows us to extract these features or variables from the text. We put it in a relational database, and then we write SQL queries on top of it, which allows us to create this patient feature matrix, and then we can do all of our different things. So I was giving you examples of clinical studies. I've not shown you examples of predictive analytics or other stuff. And I alluded to this notion of using an ontology where you can group things into other things. So you can ask questions at the level of a beta blocker as opposed to a atenolol, propranolol separately. And this black box or white box is phenotyping, which is how do you define the condition or outcome of interest, and that I'll give you concrete examples of. And as I said, it takes about 4 months to do the study, about 2 to 3 weeks to generate a cohort, and then do the rest of the analysis. And if you do the math, if it takes you 2 weeks to generate a cohort for a study, in 1 year you can do max 25. And so we said that's a key bottleneck, and we should compress it to a second, like 1 second. So this is happening in the background. And at the same time, with Chris Longhurst and Bob Haddington, I wrote this paper saying we should do this routinely at the bedside. Because when we don't have evidence, why would we not go back to the collective practice of our institution? Turns out this isn't a novel idea. We thought it was novel, but when we started writing about it and invited Bob to advise us on this, he said, look at this paper from 1975. What we're looking at here is a prognosticogram, and what we have up here is, this particular patient A has a history of myocardial infarction, no history of recurrent chest pain, no history of congestive heart failure, heart size is normal by chest x-ray. They found 18 similar patients, and then here are the associated clinical findings in that subgroup, and then the ultimate outcome, mortality, if you do medical treatment or surgical treatment, how many are alive and how many are dead. This is basically what we were proposing to do, that given your patient, look at similar patients, in this case, this subgroup of 18 patients, and then tell me something that I don't know. In this case, not looking at the therapy choices, but then looking mostly at the outcomes. And then we dug a little bit deeper. It turns out that even further back, 1972, someone had done this. and in a computerized form. And what I'm going to show you is the modern incarnation of this exact same thing. So here, their database was kind of small, 678 patients only for lung cancer. And then here are all of the variables, or features as I call them. And they have their own ways of defining those features. And you could think of that as phenotyping. So how do you define, for example, comorbidity? Any of the 10,000 other diseases somebody has, or just the respiratory disorder? So that's an individual decision you have to make. How do you define smoking? So that's phenotyping. And so you start out with this, you keep declaring your constraints. At the end of the day, they call this chart number 13, which is essentially their iteration number 13. And at that point, they found some number of patients. I think it's about 45 or so. And then they're looking at surgical treatment or radiotherapy, and then tabulating outcomes. So in some sense, this is not a new idea. It is 40 years ago. 1972 and 2012 is when we're talking about the green button kind of ideas. So I told you we're going to take that cohort building time from 2 to 3 weeks to a second. And the key problem we have to solve is how do you do phenotyping at scale? So let's go back to the same example. We want to ask this, answer this question of relative risk of thrombosis in kids with SLE with proteinuria at present any time, or in up to 60 days before. I'll tell you the answer first, and then I'll go to the search. So there's 259 patients today, 98 at that time, age 5 to 18 with SLE, and 23 have had a thrombotic event. And then in a few minutes, I can say how many of them did not have this proteinuria. So it's 131 of them. 4 of them had this outcome. 2-day proteinuria, 64. More than 60 days, 118. You get these numbers, and then you can get your risk ratios, or relative risk. So let's do this. So here's the search engine. We're searching 1.4 million people. And I'm going to take a query. Actually, I'm going to take a slightly simpler one from here, just to keep it fast. All right, so what I've pasted in here is I'm defining a child with SLE as the intersection of being between 5 and 18 years and having this ICD-9 code. I'm defining thrombosis as the intersection of either having this ICD-9 code or a mention of any of these things in your textual documents, and then, of course, being between 5 and 18. Okay? So I'm going to take this away for a second, and let's say, how many child with SLE do we have? 259. And you can see the response time up there, 0.03 seconds. This is telling us the different dimensions of data that we have: labs, notes, drug information on them, ICD-9 codes, and CPT codes. We can get some basic cohort characteristics and how many encounters we have had and for how long or what period for them. And then you can look at the other ICD-9 CPT codes and so on. All right, so that's that. Then how many kids have had thrombosis? About 1,800 total. And then I'm going to ask how many of them had this sequence of events, as in they were a child between 5 and 18 with this ICD-9 code and then had thrombosis. So the time dimension is important, and that's 23 people. So that's the one. That is the 23 we have up here. And then you can define other things, which you can see in the slide notes. You can define your proteinuria. You can define other stuff. So I'm just going to paste this in real quick. And then let's see how many of them had SLE, proteinuria, and then thrombosis. Oops, what did I do? Oh, yeah. 12 people. So you can do this. If you learn this language. It's a conversational mode computer program envisioned in 1972, working live. We can run this on proven market scan data, which the Population Health Sciences Center has procured. 140 million lives, same response times. You can search with equal speed. All right, so let's go back. So that's the idea of building cohorts via search as opposed to defining SQL queries and having an analyst in the loop. 2 to 3 weeks to 1 second. The other sort of thing I want to plant is that this question, this exact question, can be posed and answered at the population level or at the individual level. It's a subtle difference. So typically we pose questions at the population level, as in what's the relative risk of thrombosis in children population with SLE, proteinuria, and so on, and so 259 patients. So in these kids, these 259, 23 had that outcome. What we are really after is this intellectual leap that if it is true for this population, it is true for my patient, John Doe standing in front of me. So that's the individual level question. Now it's a whole new separate grand rounds to describe that it is possible to go to that individual level answer entirely skipping this population level business. But I want to flag this because that's a fundamental decision we as a community have to make, that should the consult provide you with a population level answer or with an individual level answer. And if we give you an individual level answer and you come back with lots of questions about ifs and buts of the population level estimation procedure, we're just going to talk past one another. So I just want to plan that for the future. So I showed you a quick example of defining these phenotypes. You know, so lupus, I just said if they have this ICD-9 code, I believe they have lupus. It's not perfect. For proteinuria, I would include things like proteinuria, nephrosis, nephrotic. For thrombosis, we put in thrombus, thrombosis, blood clot, blood clots in a note. Now these are choices you make based on the knowledge of the local practice of medicine. There are some places that are sticklers about coding. There are some places that coding is kind of an afterthought. And so you need to rely on surrogate things in the EHR that get you the outcome you are after. That particular exercise is called electronic phenotyping. So I already showed you this screenshot, and this is just with a few comments. So you can actually comment your code if you choose to write one. And I'm kind of looking at this side of the room because a lot of the fellows will be programming savvy, and we're happy to teach you this language. All right, so we have this search engine, and I showed you this. This flow chart. So I could go from 2 weeks now to a second. I have this search engine. We have clinical fellows, PhD students. I could just go on a roll and keep doing these studies, one a week. That's kind of boring, actually, after a while. Okay, all right. So that's why we build this idea of the consult around this search engine. I could expose the search engine to you directly, teach you the language, and have at it. You write your queries, you get your answers, do your division, get your risk ratios. But there's a nice paper from Zach Coheney's group talking about medicine's uncomfortable relationship with math. It's an excellent read. And so it's like, okay, this is tricky. Probably the IRB won't approve this. And so we put it in a wrapper. And the wrapper are people, which I'll show you on the next slide. But it's a simple 4-step process. You submit a question by emailing this informaticsconsult@stanford.edu, that email address. You define the phenotypes in English. We will translate them for you and generate the cohort. We'll run the inferential analysis, the population level one, because that's what everybody's comfortable with. And then we'll give you a report back. So the workflow is the question intake, up to 60 minutes. Here are the people involved: Lance Downing, Saurabh Gomwar, both of whom are in the room. James Tooley might also be in the room. We put people with clinical training because, as I'll show you in the next, in a few examples, there's a lot of subjective interpretation that we have to make. Then, of course, you define the phenotypes. Alison Callahan, who's here up front, she does that. And Vladimir Polony is the person who built the search engine. He's also here. And Juan Banda is sort of the keeper of the data so that when the search engine needs something to search. Kenneth Jung does the analysis, and Scott Powers, a statistics PhD student, Alejandro, a BMI PhD student, and Rob Tibshirani and Trevor Hasty, faculty in DBDS and statistics, are helping us figure out the personalized individual aspect of the inference. And then report back against the same people, and we allocate an hour for that to walk you through what the report means. So going from a study that typically takes 6 months, 6 hours. All right, so what do you get back in the report? The question as posed, because it's always important to be clear about what was the question. Was it population level, individual level, and whatnot? How we asked the question, because we translate that to phenotypes. Then our interpretation of the results. And then a walkthrough of how we arrived at that interpretation. So this will be page 1. And we have a few sample reports up here. Real question, real data, but not a real doctor submitting it. And so we'll hand them out so you can look through them. And the research walkthrough will first do the simplest thing possible. Use an unmatched cohort, just long division, to get you a risk ratio or an odds ratio. Then we'll match on age, gender, and length of the record to make sure that the people you're comparing against are at least similar at the level of these 3 things: age, gender, and length of the record. And then we'll go all out and do a propensity matched cohort. We're doing tons of stuff on having this personalized estimate, but it's not shown right now because we have 4 different options and we don't know which one is best. And then we'll also have to have that extra 1 hour of conversation to tell you how it's different. So both of those properties make it a bad idea at this point. So here's an example. This is the one that is circulating. It's a real question from a practicing doctor. Do patients with rheumatoid arthritis and COPD who are treated with TNF inhibitor have a high rate of pulmonary infections than those treated with methotrexate? It's a population level question, probably prompted by one person in front of that particular patient, particular doctor. Well, so patients with RA and COPD. So we say, okay, this ICD-9 code, this range of ICD-9 codes at the same time. Because if you unpack this a little bit, RA and COPD are both chronic conditions, but if you say RA and pneumonia, if you had pneumonia 20 years ago, are you still a patient with RA and pneumonia? When you're conversing with a clinician, these kinds of things are obvious, but when you're posing a query to a search engine, you have to be explicit about that. So same time. Then patients with RA and COPD treated with a TNF inhibitor. Now, implicit in this is that it's within some time interval, so we say within 3 months. And implicit is that there is no record of a methotrexate prescription, because you want to do this comparison between TNF inhibitors and methotrexate. But you never say that. You just say who are treated with a TNF inhibitor. But would you accept people who are treated with a TNF inhibitor and methotrexate simultaneously, if that's possible? You would accept that in this. So I see a nod here, but in this particular case, it was an exclusive comparison. Same thing with treated with methotrexate. We say no record of TNF inhibitor prescription in the same period. How do you define a pulmonary infection? Implicitly, it's this ICD-9 code and an inpatient admission. Do we want to include outpatient data? Well, in this case, yes, because we're going within 1 year. And then in this case, we had to use the Truven market scan data because our data warehouse was too small to answer this question. With 1.4 million people, it was still not enough. And so the numbers you see in the report circulating, it's about 1,000 people here, about 730-ish here, 331 here. And then the research walkthrough, well, the simple, crude way of doing it, you don't see an effect, at least no significant difference. You match on age, gender, and length of record. These numbers change a little bit here and there, but final answer, no change. And then if you do the propensity matching, it's like perfectly at 1. So in this case, the interpretation was easy, that the analysis presented do not suggest any difference. But that's contingent on how you define this. If you change the cohort to include people treated with TNF inhibitor and methotrexate versus just method, now that's a completely separate question, and the answer would change. All right, so the way we see this being used, if you have a guideline or if you know what you need to do, by all means go do it. If there's any doubt, try requesting a consult. We will attempt to generate a cohort of similar patients. Our cohort is about 1.4 million patients. It's about 2.7 million patients total, but then we throw away a lot of data where we see funky things, as in the age of the patient is decreasing, or it's a pregnant man or something like that. There's 65 pregnant men, by the way, in our data. I mean, it's all sorts of crazy stuff. So the data after the cleanup, the 1.4 million patients are the ones we trust. And then if we're able to do our analysis, we'll give you this report that gives you practice-based evidence. At the back end, what we're interested is tracking what specialty asks the most questions. How much time does it take to do these consults? How often does it fail because of not enough data, or matching failure, or there's no effect estimated, or so on. And then as a byproduct, we're going to get this priority list of those situations where there's genuine ambiguity, and we better go ahead and do a randomized control trial. So tips to get a good consult: ensure that the condition of interest is associated or can be ascertained in the EHR using a combination of labs, demographics, meds, orders, or term mentions in textual documents. These are the modalities you have to play with, but you have to tell us that when will you believe that the patient was treated with methotrexate and had rheumatoid arthritis and COPD, and in what time frame. Think of the variables you might want to control for, like age, gender, length of record are the basic things we do for free. Define the population, the intervention, the comparison group, outcomes of interest, time frame of interest. If you have limited time, focus your attention on the comparison group. That is the single most important decision you're going to make. If you change the comparison group, the answer will change. Include possible edits or changes to the variable, because if there are not enough patients meeting the criteria, should we expand the age range? Should we expand on the exact diagnosis? Because our data set, our clinical data warehouse, I mean, it's large, but it's not that large. It's larger than 678 from 1972, but it's still 1.4 million people. And then from our perspective, from the informatics perspective, the open questions we have are population level estimation or patient level prediction. Like, what should we be doing? And we'll be observing what we get to make that decision. And I'll give you one visual for the problem. There are other uses of the search engine, and I'll show you one quick screenshot of that. What throughput do we need to support? So I showed you the people involved. If all of us were doing just that and nothing else in life, this service would cost $850,000 a year. And if we just did 100 reports, that's $8,500 a report. So who would want to pay for this test? If we do 1,000, which we have the capacity to do if we're all working full-time just doing that, that's $850 a report. And if we can automate it and increase the throughput 10x, that's $85 a report. So that's what we're trying to ascertain, that all of the previous efforts failed, and the top reasons given for that were that the data acquisition costs outside of the routine care were prohibitive, that they could not sustain this. That main cost has gone away now. And then phenotyping, representation learning, how are we going to represent patients as features, patient matching, personalized effect estimates. So for the informatics folks, if there are any in the audience, these are all well-worthy thesis areas. All right, so I'll give you 2 slides and intuition around the population versus personalized. So think of these axes. So this is, I'm trying to find similar patients, and this is the probability of getting the intervention. And here is how close are you to the index case in some arbitrarily distance metric. So typically, we have a bunch of people, and we say the red ones are those that are the same age, same gender, same length of record, had the same diagnosis, and therefore had the same probability or propensity of getting the intervention. And then we get this cohort, and then we answer the question at the population level. When we start personalizing, saying they must be Indian, 39 years old, wearing a blue jeans, I mean, you're down to very few people. At that point, if you're doing population level estimation, your population is 5 people. So then at that point, is it even worth it? So that's the hard part, population level versus personalizing. And then I said the search engine had a whole bunch of other uses. So this is a little grid. I showed you the use of the search engine for the informatics consult service. We obviously can use it to keep writing more papers. You can use the search engine to look at quality of things, urinary incontinence rates, DVT rates. I'm going to show you an example of a HEDIS measure calculated with this search engine. So here is this particular one from the BCBS Texas website. It's around the number of patients with acute bronchitis diagnosis who were not dispensed an antibiotic within 3 days of the encounter. It's one of the numbers we're supposed to track. It's a 12-page long PDF. And if you translate it into queries, it'll be pretty long. In Atlas speak, it's about this many lines. And I can take those many lines and paste it into the search engine if I can find the HEDIS measure. Yeah, there we go. So this is pretty long, as you can see. It took Allison a couple of hours to write. And now I'm just going to get the numerator for that, 4,673 patients. It's almost instantaneous. And then if somebody can remember 4673, I'll get the denominator, 6377. You divide, and you get your answer for that quality measure. All right, so with that, I'll close. There's a lot of people involved. I've sort of introduced the team along the way. David Stark, who used to be with us, is now at Mount Sinai. Melissa Strader is a UI designer at Google who kind of did work for us pro bono. Funding a lot of my grants where the effort on this can be justified as necessary for them, kind of support this work. A lot of funding from the Dean's Office, or Department of Medicine, Biomedical Data Science, PHS, and some industry funding to keep the data into the right format. And without the STRIDE and IRT teams and RIT guys supporting us, none of this would happen. So with that, we had an idea in 2014. We have a product in 2017, and the button is actually green. And so send us consults at this email address, and I'll stop here and take questions. Jason.
Wonderful presentation. You asked about who will pay for this consult, and I was wondering, is there a way to tag the cost data of the group versus the control?
If the hospital gave us cost data, we can index it, not a problem. I haven't even asked for it, so I don't know how hard or unhard that is, but
You would ask the question, who will treat it with
yeah,
consult versus people?
correct. You could compute the effect estimate in dollars.
I got to ask, just draw an analogy. In the 1960s, long before PubMed, when NLM created
it's a complicated query language.
But someday you can imagine this integrated directly with the EHR. And so you're probably going to tell me don't try this at home. But what would be the disadvantage or the challenges that a clinician would have trying to pose these queries himself?
So I don't see any downside other than disappointment in the first pass. Because it takes a while to learn that language. To someone who's familiar with programming, we can probably get them functionally efficient in about 3 to 4 hours. But handling of time is complicated enough that like people who designed it still make mistakes. And then you have to draw the timeline out. I was like, oh, that's not what I meant. So the simple stuff, easy. In 3 hours, I can train a clinical informatics fellow to do this self-serve, not a problem. That's where I would want to get. When Expedia came around and Travelocity came around, the travel agent said people are going to book themselves and end up in the wrong airport. I mean, no. Yes, it does happen in like a tiny fraction of the cases. So I'm perfectly willing, and actually rather I would want to put this in front of clinicians. The question is there appetite to learn this? Because there's a decent amount of agony involved in learning that language. Bob had a question.
So to Mark's point, my former research used to have a saying that there were few things in clinical research more dangerous than a clinician with a rudimentary knowledge of SAS. There probably is some issues here. Work with the professionals. But have you thought what your metric of success here is going to be, Nigam? Part of it is generating the list of prioritization, perhaps, for further research. But have you thought about, at some point as you gather data, formally studying this? For example, could you imagine randomizing people to an informatics consult or not? And then to get to Jason's point, look at things like cost, length of stay, et cetera.
Yeah, so there's 3 or 4 ways. So the question is that have I thought of evaluating this in some ways, and then the 3 examples of evaluating it. So all 3 are on the table. In the IRB, we said we want to do this as a pilot, and then if the pilot is successful, we would want to shut it down for a while, have a washout, and then bring it back online randomized, and then look at how often does the obtainment of the consult change the treatment and impact on hard metrics like mortality and cost. We're not there yet because I want to see, do we get enough consults that are answerable using our data? Here, yeah.
Hey, what an awesome study, really. So interesting, and it seems like the way moves to the future. So I think you might have had it backwards just now, though, because in order to get people to use something, you don't build it and hope they will come, even though the movie said that. It doesn't actually work that way. You have to study how best to disseminate and implement it. And that's something that I would urge you to at least consider, because it might be that it's not a problem of, if you found that very few people were using it,
Yeah.
it wouldn't be that the language itself or the structure of the intervention itself was bad, but you had to somehow wrap it in some other way of making it easier and more facile to use, and you can study that process.
Absolutely, and I know nothing about health services research, so I think that is worth a lunch that we should have.
I know something about it.
Yeah.
So how are you dealing with the ever-increasing problems of code creep and a copy and paste problem in medical records from a practical and a methodological perspective? So for instance, if you noticed that there was a lot of copy and paste in the medical records, you might have less confidence in that particular medical record than you would in a medical record that was more substantive.
Mm-hmm. So I have 2 responses to that. One, detecting copy and paste is relatively trivial, actually, in this day and age. I mean, if we can detect plagiarized assignments of high school kids, we can detect copy paste from docs, like not a problem. The other one is that Tejal Gandhi at Harvard just published a study showing that the extent of copy paste and its impact on care is actually negligible. So we actually have an effort in my group, Juan Banda is working on it, to quantify copy paste. And when that study came out, I was like, yeah, let's put that on the slow burner later on. I mean, they say it's not a problem, so why bother quantifying it? Yeah.
So, wonderful talk, thank you. David Hellman and Hopkins has popularized this term called personomics.
Okay.
Understanding who is this person,
So,
Technology to that kind of data. I know Mark is interested in that stuff, but
yeah. So the question is that the example of a patient who was coming to Hopkins having an asthma flare-up around every September. And then it took a while to figure out that that person was a 9/11 survivor, having walked out of that building, and the flare-ups had to do with that. And so the question is, what additional things should we be capturing in the EHR to enable finding of these kinds of things? I don't have a canned answer for that, but at the minimum, what's called the new vital signs from the Institute of Medicine, the socioeconomic factors and things like that would be at least the minimum that we start to capture. Yeah.
Presentation. I have concerns, however, about the accuracy of the medical records, coding errors. Nobody checks that routinely, and incompleteness of data. You're looking at Stanford records. A patient may get some of their treatment elsewhere that may not get incorporated. So you have a little biased data set, perhaps, and you have to check for errors. As you mentioned, male pregnancies, 65%, male prostate, male GYN cancers you'll find as well, and so how do you handle inaccuracies?
So there's some things that are just impossible, and so that's how we end up throwing away about 1 million patients worth of data. And then there are some things that are incompleteness, genuine missing information. They had 2 episodes of care at Palo Alto Medical Foundation, and we don't know about it. And that's why injecting insurance data, claims data, to at least complete the longitudinal record, even if at a low resolution level, is absolutely essential. And one of the things on my to-do list is to see if we can get the insurance data for our people. Like ideally, we have the Truven Optum data sets. I would just want to match our patients to theirs. Technically, that's not a problem, but it's basically a whole bunch of legal agreements that prohibit us from doing that.
I just wonder if you looked at the patients you threw out, that million patients, and you included them, even though there were some errors, would you get console answers?
We could quantify the instability introduced by bad data. That's something we could easily quantify. Yeah, there's a question in the back. Yeah, last question.
You mentioned that physicians are uncomfortable with math, and as you move from population estimates to individual patient estimates, do you have any plans to sort of teach physicians how to use that when talking to patients to interpret that risk and with the patient in front of them?
So not the second part. So the question is that when we get to personalized estimates, do I have a mechanism to teach doctors how to talk about it? I do have a mechanism to teach clinicians on how to think about it and understand it. Actually, I teach a graduate class, which increasingly med students and fellows are taking. It's called Data-Driven Medicine in the fall. There is no component of that gives you ideas on how to talk with a clinician, but that's an excellent question, and we'll think about how to do that.